honorable chairs, the learned audience coming from different parts of the globe. Very good morning and greetings from the heart of Bangladesh. And welcome to the topic allocated for me to discuss erectile dysfunction in diabetes. I have nothing to disclose, and this is the presentation flow of mine: epidemiology of erectile dysfunction in diabetes, pathophysiology of erectile dysfunction in diabetes, management of erectile dysfunction in diabetes, and carry-home messages. We are living in the world of diabetes epidemic. In the year 2017, in December, International Diabetes Federation published the 8th edition of Diabetes Atlas, and they reported that up to 2017 in the world, there was 451 million adults aging from 18 to 99 years had diabetes, and projected that the 693 million people, again aging from 18 to 99, have diabetes. And the age group, if you consider to be 20 to 69, the number would be 415 million in 2017 and 642 million in 2045. This is the huge number, and again the prevalence of diabetes sharply rises from the age of 35 and continues to rise up to 69 years. And more, this is the time of high sexual activity for men and women. And interestingly, during this time, the prevalence of diabetes is higher in men than women. And beyond this time, the prevalence goes up in the female population. So, again, the sexual dysfunction is a common problem with the patients with diabetes, and it can be more pronounced, more pronounced among the people with diabetes, and the highest group of people who have sexual dysfunction with diabetes, this is the erectile dysfunction. And again, erectile dysfunction may be difficult to treat with the patient of diabetes. And why this occurs in diabetes? Diabetes will disrupt the sexual activity of the men and women, and between the ages, the erectile dysfunction can go up. I have told that because it will cause several end organ dysfunction, including the blood vessels and neuropathies. So, incidence of the erectile dysfunction is at least 3.5% higher in the population, men with diabetes, than their counterparts. And the large meta-analysis published by Kudrat et al., they have conducted the study, and comprising about 89,000 people with diabetes, and it has been published in 2017. And it comprises the population of all the parts of the world, including led by Asia, Europe, North America, North Africa, Oceania, South America, and multiple other continents. And the global prevalence of erectile dysfunction in diabetes, they found it would be around 75%. And you can see that all the parts of the world, the prevalence is high, erectile dysfunction prevalence is high with diabetes, and it was highest in Africa, followed by Asia. Africa had around 71%, Asia has 67%, and Europe has 54%, and in North America it was the lowest. So, in terms of risks, they found that in terms of risk, the diabetes is the most important cause of erectile dysfunction among the men, and among the diabetic population, the chance is 3.6 times higher comparing with the non-diabetic population. And the frequency of, again, the prevalence of erectile dysfunction, they conducted our study in Bangladesh. I was one of the part of this. We found around 75.3% men to have erectile dysfunction. And the Sri Lankan study again found that around 73% of the diabetic population had erectile dysfunction. So you can assume that the prevalence is very high. And not only that, the diabetic population may have erectile dysfunction at about 10 to 15 years earlier to comparing with the non-diabetic population, and it is the more severe and aggressive form, and it may not be responding to other all the modalities of treatment of erectile dysfunction, and more importantly, the erectile dysfunction may precede ischemic heart disease. So some authorities like to say that the erectile dysfunction patient should screen for ischemic heart diseases. This is again the study conducted in Sri Lanka. They found that with the increment of age, the number of patients with erectile dysfunction increases in diabetes, also in other groups, and the duration of diabetes is one important landmark of causing erectile dysfunction in the patients with diabetes. So not only that, there is a predilection of having erectile dysfunction among type 2 diabetes mellitus. In Stockholm, they conducted one study and they found that the type 1 diabetic patient has very low prevalence of erectile dysfunction, but type 2 diabetes patients, the huge prevalence they had. And erectile dysfunction is synonymous to endothelial dysfunction. It is now proven by several studies. I am citing one study, and they found that at least 2 times more chances of erectile dysfunction is in the group of diabetic population, and it is due to endothelial dysfunction. You can remember that the erectile function is dependent on the blood flow. Initially it is the arterial blood flow, and the locking is done by venous blood flow. So if there is any endothelial dysfunction, that will impede blood flow and that will cause inappropriate erection of the person. So they postulated that the erectile dysfunction, it is the the cardiovascular risk factors, other factors, they have the endothelial dysfunction, and low androgen, again they can be regarded as the pro-inflammatory condition, and if these two are combined, that will cause atherosclerosis and ultimately vasculopathy leading to erectile dysfunctions. And again, the notorious one is the smoking. Smoking independently can cause erectile dysfunction. In the patient who are having diabetes and smoker, they have the highest chances to have erectile dysfunctions. So in summary, we can say that the diabetic population has more chances to have erectile dysfunction, but how? Diabetes is a pro-inflammatory condition, I have told that, but in type 2 diabetes mellitus, they have 2 pathophysiology. One is insulin secretory defect and one is insulin resistance. And not only that, they may have other comorbidities like hyperlipidemia, hypertension, obesity, and in this part, the sedentary lifestyle is the most important culprit. So the patient may have the vasculopathy. I have told that how vasculopathy can cause erectile dysfunction, and the micro and macro vasculopathy both will cause endothelial dysfunction and inappropriate blood flow to penile vessels. So this can cause erectile dysfunction. And neuropathy, again the most important one to cause erectile dysfunction. And several studies found that the type 2 diabetes patients who are reporting to the physician, at least 30 to 40% may have initial presentation of neuropathies, and they are coming for the symptoms of neuropathy, and that incidentally found that they have diabetes. So this is the complication of diabetes. So they have autonomic neuropathy or peripheral neuropathy, and both will cause neuropathy and vasculopathy, and at the end, they will cause erectile dysfunction. This erection is initiated by parasympathetic activity and maintained by sympathetic activity. So you know that the erectile dysfunction will happen in patients with neuropathy, diabetic peripheral neuropathy. Again, the erectile function, this is the sexual function driven by testosterone. So any causes of testosterone deficiency will decrease libido, also decrease the performance and erectile dysfunction. So the patient with diabetes, it is again established that the patient with diabetes has a low testosterone level. Diabetes per se will cause the decrement of testosterone level. Not only that, along with diabetes, there may be present some other causes that can cause hypogonadism or testosterone deficiency that will again cause erectile dysfunction. Not only that, there may be some local factors like Peyronie's disease, balanitis, phimosis and fibrosis that can cause inappropriate erection, and ultimately those factors will cause the decrease nitrogen oxide release and decrease vascular activity. And again, the erectile dysfunction has strong association with psychological factors like depression, anxiety that can decrease libido, and ultimate result is erectile dysfunction. So these are the background. So you have one patient who has erectile dysfunction. Now we should have initial evaluation of the patient, starting from detailed description of the problem, and the patient should come out. Maybe a patient is shaky in the scenario we are practicing in Bangladesh, in Sri Lanka, Nepal, Pakistan, the all surface countries. The patient may not be very spontaneous to come out with the problem, but patient should be encouraged to come out with the problem. And not only that, the main presentation is the important one. Not only main presentation, is the other precipitating factors which are persisting to cause erectile dysfunction should be kept in mind, and then the medications and other factors should be encountered. And was the patient was on treatment. In Bangladesh, we are encountering several patients. They are coming to erectile dysfunction problem, and before that, they had been treated with so many alternative medicines or other things. So this should be keep in mind. And while patients are coming, the male are coming, they have problem with erectile function, but they should have clear idea of erectile function in previous days. And not only that, there is psychological issues and the partner relationship you should keep in mind. And concurrent medication, several medications can cause erectile dysfunction, starting from beta blockers and other drugs. So the patient, if the patient is taking other drugs, it should be listed out. Finally, the patient should be asked about alcohol consumption, smoking, and recreational drug misuse. So having said that, the patient should, how we will categorize the patient's erectile dysfunction. The International Index of Erectile Function is the best one, but you can use Sexual Health Inventory for men, International Prostate Symptom Score, and Aging Male Symptom Score. Any one you can use, but it should be validated for your population. So not only that, after taking the history, you should examine the patient. The all-through examination should be done, not only for erectile function, for other cardiovascular events, starting from pulse, BP, and digital rectal examination should be performed. And the examination for the focus physical examination, genital examination should also perform there, because some patient may have local problems. So after this one, we should start for management. The management, the patient is having diabetes, for not only for erectile dysfunction, for every patient. Before starting any management, we should optimize the diabetes control. And the optimization of diabetes control will start with lifestyle modification. This is neglected in this part, the poor settings of diabetes management in Bangladesh or Sri Lanka or other countries. But I request the audience to improve the quality of treatment, starting with the lifestyle modification of the patient. And patient should be individualized for treatment to improve the lifestyle modification. And not only the diabetes treatment modification, the other comorbidities or risk factor modification should also be done appropriately, because only diabetes management will not improve the patient. So patient may have cardiovascular disease, patient may have other diseases, lipid profile disorders or others. So appropriate focusing is needed to have better outcome, because employing everything, the outcome may not be good. And modification of erectile friendly drug, if many patients with the erectile dysfunction, they may have cardiovascular drugs or other drugs. So we should encourage the patient to alternate the drugs if you can do it, or if not, you can seek referral from other experts doing the same jobs. And the mainstay of the treatment of erectile dysfunction is PDE5 inhibitors. Globally, it is accepted, but you should keep in mind that the erectile, for the management of erectile dysfunction in diabetes, the dose may be the similar with the other patient who do not have diabetes, because we may need the highest dose with the patient again may not respond to the therapy. And to evaluate this one, we should again improve the diabetes treatment policy, the lifestyle modification, and dose adjustment. The dose adjustment may be the highest level with the PDE5 inhibitors. If the patient does not improve, again the patient may come out with the statement that initially I had improvement, but again we had the similar pattern before the prior to treatment of the drug. So the dose increment may help. Going up to, depending upon the modalities of the PDE5 inhibitor prescribed, you can adjust the dose, but till you cannot have the satisfactory effect. If the improvement is not good, you can have the other option. This is the transurethral L-prostadil. You can use intracavernous injection. You can use vacuum device. You can use some other devices, but at the end you can need to use penile implants. But keeping in the mind that some patient may have come out with the complication of PDE5 inhibitor, they cannot tolerate. They have flushing, they have contraindication of PDE5 inhibitor, like they have recent MI or ischemic heart diseases or recent bypass, so the patient cannot use. So for this patient, we should have to switch to the second option. This is started with transurethral L-prostadil or intracavernous injection or vacuum devices. And for selective patient, penile implants can be done. This is done by the urologist. And in our country, the limited records we have, there is evidence that the patient can improve. But India is doing fantastic, but probably Sri Lanka, they are also doing the same thing. For everything, patient should have good counseling and education. And keeping in the mind that only the male partner education cannot have the best outcome. So you should have discussed the best factors with both the partners to have best outcome of the treatment. And while choosing this PDE5 inhibitor, you should again individualize your patient depending upon the patient lifestyle, depending upon the other factors, and depending upon the time of sexual activity. You can see that the evanafil, it will start acting by 15 minutes and the elimination time is 5 to 10 hours. So if the patient have to have the intention to have sexual activity within very short time, the evanafil may be better one. But sildenafil will start acting by 30 minutes and the elimination time is 3 hours to 5 hours. So again, prescribing the drugs, you should keep in mind that the time of taking the drug and time of sexual activity. The tadalafil is the best one. It will start acting by 30 minutes and the elimination time is 17.5 hours. Why it is best one? Because if the patient misses to take one tablet, this will not hamper the sexual activity. This is the best one. Again, the patient who are taking, consuming alcohol on a recreational manner, for this patient, the tadalafil may be the better one. Vardenafil, again, the time of onset of action is 60 minutes, is the highest time, and the elimination time is 4 to 5 hours. So depending upon the patient's lifestyle, depending upon the patient requirement, depending upon the comorbidities, you should choose one PDE5 inhibitor for your individual patients to have the better outcome. And again, not only this one, this is the mainstay of treatment, but you can not avoid lifestyle modification, because in our country, also probably in Sri Lanka, India, Pakistan, the main culprit is the sedentary lifestyle of the patient. So sexual activity for the patient is strenuous activity. Although the patient is not doing any physical activity, for this sexual activity, you can assume clearly that the patient will not be performing good. So the lifestyle modification was the best one. So carry home message at the end. Erectile dysfunction may be as high as 75% in diabetes male. And erectile dysfunction is severe to treat in diabetes, and maybe in some cases it may be resistant to treatment. And testosterone deficiency should be sought out while selecting the patient for erectile dysfunction management. And at the end, not at the end, for all diabetic patients, the optimal glycemic control is the mandatory one, and associated with other comorbid should be addressed well, and for this lifestyle modification should be done. And for treatment of the patient, individualization is the prior one. and transurethral prostaglandin, intracavernosal injection, vacuum devices and penile implants are available, and that can be chosen if the PDE5 inferior response is not good. And premature ejaculation, this is again one important thing, that some patients are coming with the symptoms and the physician is thinking that this is erectile dysfunction. Not every patient is having erectile dysfunction. Some patients may have premature ejaculation. So the score I have shown that that can segregate that the patient is erectile dysfunction, and severity of erectile dysfunction is that form, and we can choose one treatment for the individualized patient.
Time
Thank
up,
you all,
please.
and love from Bangladesh.